Good evening and welcome to Psych Incubator and our production Eminent Psychotherapists Revealed. I am very pleased to have as our guest tonight a colleague and friend, Dr. Peter Costello. We are so pleased to have him here tonight and to join us for what I think is going to be some fascinating discussion and interaction, and I hope we get to hear from all of you out there. Peter is a clinical psychologist who's practiced in New York for many years. He works with individuals and couples. He's a professor emeritus at Adelphi University, where he taught seminars in attachment theory, interpersonal communication, and adult romantic relationships. And he just told me he's kind of hatching a new book about psychotherapy and romantic relationships, which I'll be interested to hear more about his thoughts. He's the author of a classic in the field now, Attachment-Based Psychotherapy, Helping Patients Develop Adaptive Capacities, published by APA. His theoretical and clinical work with patients is the subject of an APA video, which features him conducting a session with a patient whom he is meeting for the first time. I will not go on and on about you, Peter, because I think your work and you stand alone in the field. And again, so glad to have you here joining us tonight. So while Michael Albert will be joining us, and welcome, Peter. So I'll start off. So Peter and I have probably shared one of the most intellectually and emotionally stimulating nights of my career after a SEPI conference one night, where we had the honor of spending some time with Dr. Mahoney. I don't know if you were there, Kristen, but
was this in Baltimore?
No, this is
New York.
In New York. And
in New York, okay.
And we had some of the most stimulating conversation. And Peter's intellect is up there with Mahoney, so I think we'll enjoy that. But what I think is one of the things that I always found interesting, Peter, was that you have you got your PhD in communications prior to getting your PhD in clinical psychology, and how did that affect your journey into psychotherapy at large, and also with your focus on attachment? Like, how did the background in communications, do you think, if it did affect your, I know it did, but I'm going to keep it open so you can.
Well, thank you so much for the very warm welcome, and it's a great pleasure to be here. Thank you very much for inviting me, Jeff. Communication, I guess, I was something that came out of my sort of fascination, which I think many people have, with how connections between people occur and evolve, and what makes some conversations different, what makes us feel close to some people and not close to others. Also, I think I was fascinated by the technological changes that took place in this culture and society. So I started off with communication, but the frustration there was that, at least in my experience, you could talk about things, but you couldn't actually do things. And there was an interest I had in being able to actually work with people and to apply ideas. And for a long time, I thought about clinical psychology as something I wanted to do. And then finally, I got to the point in my life where either I was going to do it or I was never going to have a chance to do it. And I began a PhD in clinical psych at City University in the City College program. And that was a very, very good decision for me. That goes back now almost 30 years. So I've been doing this for a long time. But
that was a big commitment to do that after having one PhD. Yes,
right. I was a professor. I had a young family. I was so it was juggling, but it was. The other thing I should say about this is that the the background in communication became an important part of how I thought about attachment theory. And so I think my one of the things that drew me to attachment theory was John Bowlby's own focus on communication, and then the way in which I think I developed my ideas about psychotherapy growing out of attachment theory had a great deal to do with merging communication and attachment theory and putting them together.
His trilogy was so important in my development. I have, I think, first editions of his 3 volumes, and they are remarkable. I mean, I don't think he gets the honor that he deserves for the work that he did, but
yeah, he got in so much trouble at the time. I mean, there were people who were deeply offended by his approach to psychotherapy. He had been the president of the British Psychoanalytic Society, and you know, as wonderful a theorist as D.W. Winnicott rejected Bowlby's ideas completely and said he found them, I think the word he used was, may have been repulsive.
oh,
So,
wow.
so he was going against the grain in a lot of ways, and he does have honor now, but not necessarily originally.
A very long time ago, when I was in, I think just like maybe out of my internship at Connecticut Children's Hospital, John Bowlby came to speak.
Uh-huh.
And I had the honor. It's a very faint memory because I didn't even really know who he was and how important he was at the time. We were just going to as many educational seminars as we could as interns and postdocs, and I remember he was one of the speakers.
Wow.
Yeah.
Wow. What year was it?
That was probably in the early 80s.
Uh-huh. So I envy you that.
I wish I had better recall of him and what happened. I know that one of my colleagues had recorded all the sessions, and I was trying to get him to find them. He said he couldn't find them, but they were documented somewhere in the hospital system, but never could.
There are actually very few recordings of Bowlby in his last years, in the last decade of his life, in the 1980s. So they'd be worth having.
Yeah.
It's certainly different today. Everything's recorded.
Yeah.
And I'm wondering, I was going to ask you about how you use these ideas in psychotherapy. How do you? I understand how you got it together, but I'd like some examples of how you do it. But I'm actually wondering, since things were so private back at the origins of psychotherapy, whether you want to say in the 20th century, but the first half of the 20th century, certainly. And, you know, we kind of show everything. And what stops us is HIPAA, or we show more. Do you think that helps people if they can watch themselves and listen to what they're saying, listen to their voice tone, watch how they move?
Yeah, I think that's very powerful. I think Kristen's had some work in videotaping of psychotherapy sessions, and I've done it as part of my training primarily, or my postdoctoral training, and then I did it for a while with patients. And I think it is very powerful to actually see yourself in an interaction with other people, or to see yourself experiencing emotions in talking about some particular event or problem in your life. And I think it gives people information that they don't otherwise have. It gives them a direct visceral sense sometimes. So the capacity to record, I think, has added a lot. The pandemic interrupted our old ways of doing psychotherapy, so we all wound up on Zoom or on telephone, or I found it very, very interesting to be able to talk to people in that format, and it's different than than being in the room with them. You know, there's something you get which isn't visual and which isn't just oral, just the sound of voices. But at the same time, there's a accessibility, and there's the possibility for the person to see themselves as they're talking to you in a way that we usually don't. And I think that adds some layers to the interaction with the patient.
So, I'm going to flip it back now to the original question. So how did you, how did this evolve, this kind of interest in Bowlby's work to, and then how you applied it personally?
Well, I think my interest in Bowlby's work grew out of an interest in authology, actually, in the study of the biological bases of behavior. Mm-hmm. And it grew out of some struggle with, I think, the classical psychoanalytic models of motivation and of therapeutic change. And it grew out of Bowlby's focus on, that very wonderful, intimate relationship between a mother and a child, and how what happens in that relationship unfolds in the rest of our life. So Bowlby thought that the main difference between what he was doing and what Freud had been doing was the motivational primacy that Bowlby attached to the relationship between the mother and the infant, and the desire of the infant to form an attachment to the mother. So that attachment for him was a primary motivation. It overrode almost anything else in the infant's developing experience of the world. And the most important thing for the infant was to find a way to be connected to his mother. And Bowlby placed this very squarely in within evolutionary theory as something that was necessary to the survival of the infant in what he called the environment of evolutionary adaptiveness, in which we most recently evolved our most human characteristics. And so the connection to the mother was something that the infant sought from the first moments of life. I'm in the interesting situation of having two new grandchildren, twins, who are just 2.5 months old, and they live nearby us. So I'm able to see them a lot. And you can see the reaching toward relationship that each of them is doing. You can see that when one of them catches their mother's eyes, and they have a very, very good mother, the intensity with which they look at her and begin to move their bodies in relationship to her. And it's a very, very powerful process. So, without going into my own history, I think we're all to some extent vexed in our relationships with our mothers. But the understanding of the way in which early relationships unfold, and the conjoining of that to evolutionary and ethological theory became something that was very, very appealing to me. Bowlby's idea about the primacy of attachment motivations led also to the idea that we're formed in those relationships, and that the self takes shape in response to the experiences we have with our mother or attachment figure. It's usually the mother, but not necessarily the mother. And that shaping becomes fateful for our later relationships with romantic partners, for our ability to do adaptive actions in the world of work, and becomes the form that we take as we go through life. And that's really what a lot of my theoretical focus and work has been about. I probably stop there for a moment and
Kristen, I think you have something that you wanted to say or ask.
Yeah, I'm having one of these like synchronistic moments because I feel like you've been listening to my sessions today because they've all been about attachment and about how our behaviors are linked to our relationship with our mother, and what is it that we needed to do in order to gain the attention of our mother, the care of our mother, the love of our mother. And so if that's what you're picking up on is just this idea that the behaviors that we bring into relationships, really come from, how we survived in our primary or our first relationship. And so I've just been watching it all day in my sessions.
Yeah. There's an example that I think helps me to think about the way in which attachment shapes us, which is the example of infants learning to speak. And, that's communication, and it's also connectedness to another person. But that as infants learn to speak, they go through a period where they babble all of the sounds that the human vocal apparatus is capable of making, all of the phonemes that are used in all of the languages of the world. But what happens over time is that some of those sounds are responded to, let's say by the mother, and some of the sounds are not responded to. Some sounds the mother herself makes when she talks to the baby child, and some sounds she doesn't make. And gradually what happens is that the infant loses the ability to either make or to hear even the sounds that the mother does not make and that the mother does not respond to. So that the babbling sounds become winnowed down to the phonemes that are used in the language that the mother is speaking. And I think that's actually a good metaphor for what happens in lots of ways in our attachment relationships, that there are certain ways of being with another person that our mothers prefer or need to do. They may not prefer them actually, but they may need to do them. And that those ways of being with another person become how we learn to be with our mothers, and therefore how we learn to be with other people. What our mothers can't let us do, we have trouble doing in other situations. And what our mothers encourage us to do, either directly or indirectly, we become very, very good at doing. So just to go a little bit further with this example, a mother who is distressed by her baby's distress in a way that makes her want to withdraw is going to teach her child to have an avoidant attachment because she's going to not respond to the child's distress except by becoming irritable or herself moving away from the child, disconnecting from the child. And the child, without understanding that, feels it and begins to discover that if he communicates distress to his mother, that she'll step away, that she'll move away from him. And that's very aversive for him. That's the loss of the attachment connection. On the other hand, if he doesn't present her with difficulties, if he suppresses his own negative experiences and he suppresses some of his own needs, his mother's more likely to stay close. And so he learns how to do that. And that gradually becomes the way in which he approaches relationships with other people. For someone who has an anxious attachment, the problem is very likely to have been an inconsistent mother, a mother who sometimes was available and who sometimes was not available. And she may have been distracted by pressing problems in her life. She may be self-preoccupied for any of a large number of reasons, but she's sometimes there for the child. And then sometimes unpredictably, she's not there for the child. And so the child becomes an expert at gathering her attention. And he becomes good at demanding her attention in ways that make her respond. And so you get this sort of heightened communication and heightened affect that's characteristic of an anxiously attached person. You get hypervigilance for the other person disappearing. I have a good friend who, whenever she would leave a message on someone's phone, about half the time, she would partway into the message say, "Gee, I hope this is getting recorded." And you know, the fear is always that the other person isn't hearing her, you know. So that kind of sensitivity to the mother's withdrawal becomes part of the child's behavioral repertoire and way of conducting a relationship.
So Peter, when it comes to clinical work, I find that a lot of the people that I work with that have had previous therapies that may not have been successful, whatever that means, sometimes multiple therapeutic experiences. And it seems in the process of engaging them and working with them that we get to a point where I start to talk to them about pre-verbal trauma and about state memory, which state memory is, I don't know how it's talked about in the in most of the clinical literature, if at all, but what I tell the patient is that they're remembering a state of undifferentiated emotion that is part of their trauma network, and that and the way that I frame it for them, it's probably states that you experienced before you had any linguistic ability to put these into words. And then we begin to try to work on what activates those states, and then how for me to try to help them start to differentiate all the emotion in that state. So how do you work with that kind of patient, that attachment, developmental trauma, attachment trauma? You know, clearly the attachment trauma is trumping all the other symptom expressions and constellations that they come in with: the marital difficulties, the depression, the anxiety. And you get to a point where it's just like a whack-a-mole. You treat the anxiety, depression pops up. You treat the depression, the eating disorder. It's just because it's state memory from early attachment. How do you conceptualize and work with those more complex, symptomatic patients who likely have kind of attachment trauma, like in the clinical sense?
Yeah, the way I work with patients generally, and that includes patients who have had some kind of real traumatic experience in their past, is to go back and forth between the present and the past, and to use a focus on emotion and communication as a way
about that. What, say a little bit more, unpack that a little bit more. Focus on emotion. What do you mean focus on emotion and communication? Tell us more.
Well, so for example, let me take a patient and disguise her a little bit. But she was one of 4 children. In the early years of her life, when she was about 4 or 5, one of the older children became very, very ill and needed to go out of state for treatment. Her mother went out of state, leaving her with her father and the other 2 kids. The father had a drinking problem, and she was alone in the house with him and with the other children. Her mother was actually gone for a period of several months. And before she left, the parents had been fighting intensely. And then when she came back, the parents fought intensely and then separated. So this was sort of a more or less slow motion trauma. where there was not a single instance or a single focus, but there was a gradual accumulation of a lack of caregiving and a sense of being endangered and an inability to tell anybody what was happening, really. And also fear for the health of her sister, and fear about what was happening with the other children at home. So what happened for her, I think, is that she became a very controlling person. And she became someone who tried to keep all the pieces lined up very, very carefully. And this shows up in her present life in ways that are causing her difficulty. They're causing her difficulty with her husband. They're causing her difficulty with her extended family. She has children of her own, and as they get older, she's having difficulty because of her attempt to control them in an exact way. And this is part of her approach to her own emotional life and part of her approach to relationships. So in working with her, the emphasis is on what happens when she can't control something, what happens when she couldn't control something earlier in her life, right? What happens when someone in her present life moves away from her in some way, separates themselves from her, right? And in the conversations that occur in therapy, you get into a lot of detail about what's happened, and also you get into a lot of affect, of course.
And you also deal with so I keep thinking about the psychodynamic transference past present triangle. And do you get into the actual feelings with you as well as part of that, like how she controls you?
I do, although I tend in my work to be a sort of very I don't know what the right word is, but real or natural person. I don't get terribly analytic or removed. And so I think I probably focus a little bit less on transferential aspects of the relationship with me than I do on real aspects of the relationship with me. I mean, certainly transference comes in sometimes. Sometimes a patient will think that I, for example, don't like them, or that, you know, I'm late for a session because I don't want to be with them. And we work that through. But it's I tend to be very, very focused on making a relationship between the problems that the patient has come in to address and their early experiences and the way in which they process emotion and communication. I mean, I think I should say that my sense of the ways in which attachment experiences shape us or misshape us is that they affect how we process our own emotions, and they affect how we communicate to other people. And this is really very, very much what Bowlby was talking about. So it's, you know, it's all coming directly from him. You know, to take an example of another trauma case, a youngish woman who had been sexually abused by her grandfather over a long period of time, and had never been able to tell anybody about it, presented as someone who was in many ways very suppressed, and she was unhappy, she was depressed, and she had no successful relationships with a romantic partner in her life. But she was, you know, unfailingly polite and proper and articulate, but almost never about emotional content. And so what you see there is you see someone who has had powerful experiences that she hasn't been able to communicate to anyone, and that she hasn't been able to experience affect with. So my focus, you know, for example, with her was there were moments in the therapy when, and she was a very difficult patient to work with because she actually didn't give you a lot, and at least initially, to work with. But there would be these transitory moments of sadness that would pass across her face. And I would ask her about I said, I thought you looked sad there for a moment. What was that about? And initially she would say that, no, nothing had happened. She wasn't sad. She was fine. And then, 10 minutes later, or 5 minutes later, another moment of sadness would go across her face. And so gradually she would begin to focus on the emotion she was feeling. And since I was recognizing it and talking about it, it was impossible for her to talk about it. And gradually the story began to come out. And as the story came out, the emotions come out also. So for Bowlby, the thing is not that something bad has happened in someone's life. The thing is whether or not they can talk about it, and whether they can actually bring it into contact with other people, whether they can reach what Edward Tronick called a coordinated communicative state, where the patient and the therapist, or the patient and the other people in their life, are communicating about the same thing in an open, transparent way, with understanding and acceptance. And that in itself, I think from an attachment framework point of view, is what's curative. If you look at the adult attachment interview, for example, which is an interview designed to surprise the unconscious and to elicit experiences having to do with early attachment. And there are three ways in which, or more than three ways, but let's say three ways in which one can be categorized on the basis of the adult attachment interview. One is that one is secure or autonomous. Another is that one is dismissive or avoidant. And a third is that one is preoccupied or ambivalent and resistant. And what determines which of those categories one falls into is not what happened to one, but how one is able to talk about it. And if one is able to talk about it in a way that's concise and that's accurate and that's open, that tends to put one in the autonomous category. If one has almost nothing to say about it, that puts one in the dismissive, avoidant category. And if one can't stop talking about it, if one can't maintain boundaries or sort of reach a state of self-regulation about it, that tends to place one in the preoccupied or ambivalent resistant category. And those are functions of communication, really, rather than functions of experience. So to go back to your question, Jeff, what I try and do is to spend pay a lot of attention to the emotions that a patient is feeling as they're talking about something, and to the kinds of difficulties, the adaptive difficulties they're actually having in relationships and in their life, and to inquire into those until I begin to find some connections between those difficulties and their early life. And then we elaborate those. So another word that I think is very, very important in an attachment-based psychotherapy is the process of elaborating the patient's experience, of having the patient talk and unfold and go deeper into what their experiences have been. The patient who I was talking about earlier, who had been sexually abused as a child, said at one point, and I wish I could quote her exactly, I have it written down, but I don't have it handy. She said, I have all these feelings and they just come over me and I don't know what to do with them and I don't have anything to say about them. E.M. Forster is often quoted to have said, I don't know what I think until I see what I say. And Bowlby also thought that it was in the process of communication that we became able to process something that had happened to us, and that if we couldn't communicate about it, we couldn't process it. So all of this leads to a focus on elaborating the patient's experience, and particularly elaborating those parts of their experience which have been defensively excluded from their awareness, that they've kept out of awareness, that they've kept out of coordination and communication with other people.
It's amazing to me because you're like summarizing things that I know as a clinician are like spot on. And also with the research that we've done with, watching therapist and patients video recordings. And, one thing that I've always kind of felt is that the voice is such a healing tool.
Mm-hmm.
And as I'm listening to you, I'm receiving validation on that, like that, mother's voice, therapist voice, patient's voice,
Mm-hmm.
and just our ability to like communicate with one another is so healing.
Mm-hmm.
And then, I know when I'm working with patients who have been traumatized, early childhood trauma, who happen to be quite stoic, a lot of them are male. I find that when they do open up about their trauma or what they have experienced, I just tell myself to be quiet, and that if all they do is talk about it, then, that's the cure. And
your responsiveness to them, and you're hearing it.
yeah, and a lot of times it's just, can we help them, let go of the defenses and regulate the anxiety and just begin to open up and talk about the story or what happened or what they're experiencing in the moment.
Right.
And if you were in my brain, you would hear me just say, just let them talk, just let them talk, just let them talk. Because I have to regulate myself that I don't like interrupt or, get excited or change the subject. And I think the trick is like, how do you help someone get to that point that they can open up and talk? Like, so this is very helpful. Yeah.
Well, thank you, Kristen. That's it's very interesting what you say about the voice. Also, Beatrice Beebe, as I'm sure you know, has also done a lot of work on the matching of vocal intensities and rhythms and how that affects the other person. I mean, it's an interesting question about how you help the patient to unfold what they're doing and what they're feeling that they don't have access to. Paul Ekman, who, as you know, has studied human facial expressions and their correspondence with emotion, has said that he thinks anybody can get good at reading facial expressions by doing two things. One is by being very, very interested in facial expressions and looking at them and thinking about them all the time. And the other is by constantly revising what you think someone else's expression means, what they are expressing, so that not to decide and end it there, but to sort of stay interested in understanding their facial expression.
That reminds me of some of the research that they did with people diagnosed with borderline personality disorder. When they show them neutral faces, they rate them as angry.
Yes, right.
Right.
And yeah, absolutely. So the the process, I think, of being very interested in our patients, being very attentive to them, as you said, staying out of their way, inquiring to subtleties of expression or subtleties of feeling, asking them about what they were feeling when something happened, which all therapists, I think, do, and then unfolding it. I mean, there's nothing, I don't think there's any particular thing that as technique, maybe that's not right, but I don't think there's any particular thing as technique that an attachment therapist does that is any different from what most other therapists do. And John Bowlby himself was extremely eclectic and welcoming to all forms of therapy, everything from
It's more like a framework, right? Of a lens with which we view the human relationships and discourse.
Yes, it's a framework. It's a theory of motivation. the motivation to be attached and to stay connected to people. It's a theory of how we become shaped by our attachment experiences, how we become shaped in our emotional processing, and how we become shaped in our communication, in our communicative capacities and incapacities. And it's also a sort of guide for where you want to go. I think one of the ideas that from attachment theory that hasn't gotten enough attention is the idea of Bowlby's idea of an internal working model of the self and other in interaction. And Bowlby thought that out of our attachment experiences, we internalized a sense of the other, a sense of ourselves, and a sense of how the two interact. And each of us has probably multiple internal working models, but some of them are more dominant and more important to us than others. And for Bowlby, those arose out of the attachment relationship and out of adult attachment relationships also. So the internal working models continue to unfold and develop. But sometimes in therapy, that's what I think of myself as actually working with the patient's internal working model of how relationships work, of their sense of themselves and their sense of the other person. And so very often, I also inquire very closely around interpersonal conflicts that the person has, or interpersonal disabilities that the person has.
So Peter, what would you say? What would you say makes attachment-based therapy distinctive from, say, all the other therapies that we know about in practice? Like, what would you say is the secret sauce that makes it unique or different than? Because it's like what you're talking
It sounds
about.
like McDonald's, the secret sauce.
Like what you're talking about sounds like what I think we all would say. Well, we all do that. We all do that, Peter. So tell us what makes it distinctive.
I think the focus on the relationship, which I think has become a major part of most psychotherapies now. The relationship that in the way I work, the relationship that the patient has with other people. I think that the inquiry around what the person cannot do in terms of communicating, what they can't express well. I was about to give the example of a patient who, when he was a child, he had a mother and father who worked outside the home. He and his brother would come home from school at 3:30, and there'd be a list of chores they had to do. Vacuuming, they actually had to do laundry, and if they didn't do them all, the mother would be very, very angry with them and would basically withdraw from them. And would not speak to them for a while. One of the things that the patient learned was that things have to be done in an exact way, but he also learned that you can't get angry at someone, right? And you can't express direct anger at someone who's doing something that's upsetting to you, because that just makes them withdraw from you even more. In his marriage, he was extremely passive aggressive. He would constantly indirectly express disagreement or hostility or anger in a way that was confusing and displaced. And there were things certainly in the relationship that he was entitled to be angry about. But for him, the inability to express anger was something that had developed out of his early attachment relationships, and that impaired him not only in his marriage, but also at work, also in his friendships, in his continuing relationship with his parents. So in the work with him, part of what was at issue was making it possible for him to more directly express disagreement and even anger in an appropriate way. Now this is something that I think many therapists would do. And, you can think of it as a form of assertiveness training, but the focus in the attachment-based therapy is understanding, I think, both the origins of it in terms of his early relationships and also the particular emotional fears that he has about expressing anger, that the other person will withdraw from him and leave him. And that in leaving him, he'll be alone and he'll be worse off than if he had never expressed the anger. So it becomes a way of understanding motivations and impairments in functioning.
I was going to ask you, so how psychoeducative are you in this attachment-based therapy? How
I do some psychoeducation.
like you explain this stuff to people, like you had an insecure, anxious attachment with your mother, and now you're reenacting that.
I try not to explain it abstractly, but I try and go back and forth between, for example, he brings up the situations with his mother, right? If I do a developmental history with him, that's what comes up. If I do early memories with him, that's what comes up. If I ask him for 5 adjectives to describe his relationship with his mother, which is one of the questions in the adult attachment interview, he brings these things up. And I go back and forth between his experiences in those early relationships and his experiences with his coworkers, with his wife, with his friends.
It's interesting, Peter, listening to you, because we've spoken with a lot of attachment experts, but there's something about how pertainable the information is that you're sharing. Meaning, I'm hearing you talk to people about how they're interacting with other people and like what's working and what isn't. And then I'm like, well, of course you see that so well, because you're also a couples therapist too. So it's not just about attachment between the therapist and the patient, but it's also about the attachment between two people and what happens when they come into the room with you.
Right.
And
I love doing couples therapy for exactly that reason.
Can hear it. Yeah.
It's because you actually see them in interaction, and also the partner knows things about the partners know things about each other that it would be very, very difficult and very, very slow for the therapist to get to. And so you have the unfolding of the relationship. And, I've had patients who had a partner who was crying on the couch next to them, and the one partner didn't see the tears, right? And so it was something they had trained themselves not to notice, not to see. And that came out of their earlier attachment relationships, but it was something that was impairing the relationship with their partner and with many other people. And
oh, go ahead. No, I'm just wondering, like, getting back to what Jeffrey was asking, like, would you in that situation explain to someone, like, what they're doing or not doing, and offer them some education around that? Or
I often try to make each member of a couple a little bit of the therapist of the other person, in the sense that I try and talk with them about their partner's experience and where they came from in terms of their own intimate relationships in their early life, and why certain things are difficult for them in the relationship. So couple I'm seeing now, the husband gets very upset if the wife is less than sympathetic to a problem he has, and he can actually go into a funk for several days. Well, he had a mother who was bipolar and perhaps worse, but who it's actually a very long story, but who would often become very, very hostile to him when he had needs. So to explain to the wife that he's getting triggered in a way that has to do with his early life and with specific aspects of his relationship with his mother when she does certain kinds of things, makes her a little bit more aware of what's happening to him when she does something that seems very natural to her. From the other side, she had a mother and a father who tended to be somewhat narcissistic and intrusive and self-directed. And so for her, when he's asking to have a need met, very often it has the aspect of taking away her own ability to focus on her own purposes and her own goals. And she feels impinged upon. So she gets feisty and rejects it. And for him to see that about her, moves them into, to the extent that the understanding takes hold, moves them into a different place with each other when those kinds of interactions occur. And, I don't think of the difficulties as ever disappearing. If they live to be 85 years old and are living together, I think they'll have some of the same sort of difficulties. But the emphasis is on making the difficulties less severe and less disruptive and making them easier to get out of quickly.
Yeah, that sounds very empowering.
I think Lee McCullough
Mhm.
used to talk about kind of affect phobia.
Mhm. Yes.
And it's, it seems like it's more than a phobia. It's almost blindness.
Yes.
Mm,
That. Go
that's
ahead. Michael, I'm sorry.
beautiful.
That's a good, you should
Yeah.
write that.
You're in the
Affect
zone, Michael. Yeah.
Yeah, that's affect blindness is interesting.
I think that's so true. Like, we'll have to talk about this
Yes, yeah.
a lot.
It's
Yeah.
it really
I can-
is different than affect phobic. It's an actual, like an alexithymic thing, like it doesn't even
Yeah.
register.
That's
Right.
one of the reasons I like the example of the baby's babbling and losing the ability to hear or to
Yeah.
make certain sounds.
Oh my gosh. Yeah.
That one actually loses the capacity to see certain things in other people, to be aware of certain things in oneself, or to communicate about those things to the other person. One of Bowlby's most important essays was about things that we're not allowed to say or to feel or to do or to know. I think, calling that affect blindness is a nice summary term for that.
Yeah. I think we need to do another one on affect blindness.
Can we please do one on that? I was talking about darkness today, not blindness, but we need to discuss this more.
I was curious because I want to think these things link up that you were talking about. Bowlby found, what was writing about what people are allowed and not allowed to do.
Mm,
And my own experience is that the more I reveal my emotions, as we talk about different things, that it's okay for them to reveal their emotions, the people I work with.
yeah,
And
that's so true.
that you create a very emotional atmosphere, which kind of lubricates the whole process, because it becomes alive and meaningful, and people, I first kind of bumbled across this when I realized that as I was doing this, that I couldn't wait to go to the next session with each patient. I mean, the sessions were becoming more joyous than anything I could imagine, because it was just such a feeling of being alive in so many different ways. And then I think, well, I look at TV or read a book or go to the theater or, talk with some kids or my family. And you actually, I think it's, a very wonderful thing that we get to do. And on the other hand, it bothers me that but the world is not that way.
Why do you think that is, Michael, that the world is not that way?
I think, people have obviously learned, well, look, we get told not to cry, men don't cry. Like
Right.
a football player.
Don't show any emotion. Yeah.
Um, and even women are, although they can cry, they get criticized for it. So here's this wonderful emotion. People cry with happiness, with sadness, but you're not supposed to have it.
Mhm.
And I think that it goes, you could probably say, for, someone is upset and you want to comfort them and
Well, empathy. So when someone's in pain, that's why I think we have trouble with psychopaths, because when someone's in pain, for most of us, it activates our empathic response. I'm really interested in what you're saying, Michael, about this kind of this intense engage joy. And I'm thinking about the patients that I work with from 45 minute to 45 minute, and I think the key to that for me, because my patients say, "How can you do this all day long, back to back, back to back?" And I think it's because of engagement. When I'm engaged, if I can't engage someone, I get bored.
Mhm.
If I can't find some point of meeting them on the road to somewhere, so if I can't join their journey somewhere and engage them, then I get bored. But if I engage them, the day goes like it's
Mhm.
yeah,
like what you're talking about.
yeah.
And you're persistent.
My I'm gonna. After a while, my wife started saying to me, you're running over in all your sessions. You can't do that. So I said, yeah, but it helps them. And she said, but
Well, affect and intimacy, right? I mean,
Yeah.
very powerful potions.
they certainly do. So I think that I was thinking talking about getting bored, Jeff, when you have somebody you can't connect with. And I was thinking of a woman I had as a patient who would come into the session, and I'd look at her, and it was as if she had, and she just, just you couldn't see her eyes. And I said, "That's how are we going to work if I can't see your eyes?" And she said, "Well, that's your problem." But
What's that phase about seeing the whites of their eyes?
well, you can't see anything. You can't see that. You can roll your eyes up if you look.
Yeah, but there was a saying that don't shoot until you see the
Whites of their eyes. There was a phrase like that.
That's a different situation, I think.
yeah, but maybe not. Well, listen, it seems like we have 2 minutes left. My daughter, when she co-hosts, she always asks this question, and I think in her honor, I want to ask it. What would you tell Peter? What would you tell early career psychotherapists? What gift would you give them about our work or about their journey as psychotherapists, for the people who are early in their career? What advice would you give them?
That's a tough question. I think it's different for different people. And
We ask the tough questions here, Peter. That's
yeah.
what we're known for.
Enough powder puffs.
This is hardball. We
Hard
ask
for me to come up with an answer that I think is not just a cliche. I mean, they should do therapy. They should read. They should listen to their patients. They should try and get their patients to talk more than they do.
Yeah, okay, that's a good one.
That's
that's a helpful one, because when we're young therapists, we are anxious and we try to psychoeducate a lot.
right. I think learn how to facilitate the other person's communication. and try to stay out of their way. Look for the deepening of the conversation, those kinds of things.
Well, thank you, Peter.
So intense.
We're going to stop.
Wonderful time, wonderful time. You're just, I can only say you're sweetie pie.
We're going to stop the recording, but we're going to be here for the participants. If you want to watch us talk without the
Misbehave.
yeah, misbehave for a little while. We'll thank you very much, Dr.
Pleasure, a real pleasure.
Yeah, it's the attachment. It mobilizes all these